I want to talk about ALS in this lesson. This isn't a condition where we basically throw hope to the wind and tell the patient goodbye as soon as they're diagnosed. It's not really like that. I know a lot of people do that with chronic conditions because that is the feeling that, oh my gosh, your life is now got a finite point and wish we could have had better times with you. But I mean, honestly, don't all of our lives have a finite point? I mean, we're all numbered. All of our days are numbered, I mean. So, some it's going to be sooner or later, but by no means does this mean all hope is gone. What this really means is that hope is going to be restructured, and life and the dreams, they're not gone as well, they're just restructured. I think the nurse is at a very pivotal position to help a patient walk through this process of grief and loss. And so I hope as you listen to this lecture, you're going to pick up on some of the physical things we want to do for the patient. But even though I don't go really into what are the social and spiritual things we can do for the patient, that is really probably just as important. So that is something I like to pick up a little bit more heavy when I talk about cancer care for the oncology patient. But for now, I'm really going to just focus on the physical care of this person, of this patient with this disease. You get it. All right, ALS. We also know this condition as Lou Gehrig's disease. It is considered a lower motor neuron disease. Well, what does lower motor neuron mean? It means a condition that is affected from where the nerves from the spinal column reach the muscles. So somewhere in between that process is where the disease is occurring. As you may have already read, people with ALS do not usually live past 3 years. However, that is just a projection. You don't exactly have a 3-year timeline set on your body. Okay, you will expire exactly in 3 years. Yeah, it's not like that. It's just a general number. A patient will have the gradual onset of muscle weakness, muscle wasting, and spasticity, like being spastic. Spasticity. Blah. All right. Usually sensory and autonomic nervous system is not involved, meaning a person will actually have most of their cognition all the way to the end. However, we have found that some cognition and behavior dysfunction can occur, but it is not common. I'll say that most people remain intact. This disease is chronic. It is progressive, it's considered debilitating, and it is incurable, and it invariably leads to full body paralysis. What is probably going to affect the person the most is the fact that they're going to die of respiratory failure because of the paralysis of the respiratory muscles. This is Lou Gehrig. This disease has been around a whole lot longer than him, but we do know ALS became a little bit more prevalent after he came down with a diagnosis. In fact, he wrote in his last speech, he said, "Fans, for the past 2 weeks, you have been reading all about me, about the bad breaks that I got. Yet today I consider myself the luckiest man on the face of this earth." He actually died 3 years after his speech, and I'll let you think about why he felt that he was considered the luckiest man on earth to come down with this diagnosis. That's something to ponder. Right, so there is no cause, there's no cure, there is no specific treatment plan, there is no standard method of progression, and there is no method of prevention when it comes to ALS. We have found, though, that it is more common in men. However, women can still be susceptible to ALS. When we are looking at the symptoms, Early on, a patient will have unexplained weight loss. They're going to be actually too weak to eat, and you're going to notice some dysphagia, so some trouble swallowing. They're going to have fasciculations of the face or maybe the tongue, and the tongue is going to be atrophied, and fasciculations are like twitches. We're going to notice that they're a little bit on the clumsy side, and the official word for that is dysmetria. They will drop things, they'll knock things over, the proprioception is going to be a little bit off, and that's due to them not being able to control their muscles as well as they would like to. As the disease advances, the legs are going to be weaker and a person's going to become chair-bound or wheelchair-bound, and then they're going to be bed-bound. They're not able to support themselves enough to walk. We're going to see that their respiratory muscles are also going to atrophy and cannot expand their chest to take deep breaths. The picture I have here is of Stephen Hawking's. His condition was actually first diagnosed when he was 21. He was not expected to see his 25th birthday. However, he passed not too long ago, and through his condition, he was able to still pursue his dreams, and he became this famous English theoretical physicist, and he was actually the director of research at the Center of Theoretical Cosmology within the University of Cambridge. ALS complications. So we know that they often die because of respiratory failure, so you can anticipate doing pulmonary hygiene interventions. We are going to notice that they are prone to bed sores. So as you can see the picture here, everything has got to be padded and it needs to be assessed. So if you notice that somebody is bedbound or chairbound, flip and look. We are at risk for aspiration, so you can anticipate modified diets, thickened liquids, maybe even a PEG tube. They are at risk for injury, and this is usually due to falls, or maybe their arm can get caught in something, or their toe gets turned under, maybe they roll over something. They still can feel. They do have all pain sensation, just can't move. The pulmonary embolism risk is increased because of the person's immobility. Yep. The last two are sort of self-explanatory. Yeah. We're going to do a lot of medication administration for this patient. The first medication we need to make sure this person gets is Riluzole, also known as Rilutech. This drug has been proven to slow progression of ALS symptoms. It is the only one approved, and it is extremely pricey, or it's very pricey. Please make sure to administer on an empty stomach. It can be toxic to the liver, so let's make sure to grab a hepatic panel and to evaluate their liver function and to educate a patient what is jaundice, what is icterus, ascites, dark amber urine. All of those signs and symptoms should be something the patient should be aware of and can report to you if they notice them. This disease is associated with pain and discomfort, so we're going to put our person on long-acting morphine known as MS-Cotton. Prior to this, we probably should assess their blood pressure just to make sure it's good, but I will say if a person is end of life, having a high blood pressure doesn't matter anymore. If we are, when I say end of life, I mean 6 months or less left to live. All right. If they're just having not so much severe pain, but they are uncomfortable, we can give them Ultram, also known as Tramadol. Tramadol is a very weak narcotic, but it does a pretty half-decent job of controlling just mild to moderate pain. For muscle spasms, we're going to give them Baclofen. What do we need to know about Baclofen is just to check a blood pressure prior to giving it. No, it is not a narcotic. However, it can cause somebody's blood pressure to go down a little bit, and it can make somebody extremely drowsy. Another good medication is tizanidine, also known as Xanaflex. That's popular, and it doesn't have as strong of an effect as Baclofen. Still good though, it works. Because our person is going to have issues with swallowing and airway, we can give them sublingual atropine drops. You'll actually drop these atropine drops, which, by the way, they will say ophthalmic drops on the bottle, so it says it's for the eyes, but we actually will give it under their tongue. And this is a cholinergic medication. It's actually going to cause dry mouth, which is desired, otherwise they're kind of choking on their secretions. Guaifenesin, this is to help loosen secretions. It's a mucolytic. Make sure a person has a high intake of water prior to taking this medication. Maybe they're on some kind of fluid bolus regimen through their PEG tube. We are going to probably anticipate a tracheostomy, and we're going to give humidified oxygen. All of your trach care will apply here. Trying to think if there's anything specific I should bring up. Suction PRN, humidify the oxygen, trach care at least once a shift, and PRN. Don't take the collar off without applying the other one on. Have an obturator and a new trach kit at bedside, as well as a BVM bag. Okay. And sleep. They do have a lot of sleep disturbances, and so it is recommended that they can just take Benadryl to help them stay asleep, because they do tend to have, like, they wake up frequently throughout the night. To diagnose ALS, we can, as we're ruling everything out, maybe we'll notice that one of the enzymes called creatinine kinase, this is an enzyme that's released from the muscle, from the heart, I believe even from the brain. And so when it's released, the levels are going to rise, but it's not very specific to the muscle. So a lot of times we'll do other tests in addition to see that they have an elevated CK. All right, so if we were to do a pulmonary function test, as you can imagine, since the respiratory muscles are affected, we're going to have poor PFTs. To truly diagnose this and we rule everything else out, we're going to do a muscle biopsy and we're going to see atrophic fibers. Atrophic fibers. That's how we know that this person has ALS. And because we are probably going to suspect a level of MS2, because MS has a lot of the similarities as ALS, we're going to probably do an EMG. That's where you stick a little probe inside the muscles and you see if, once you stimulate it, if there's some excessive jitters. And it will show extensive jitters and fasciculations, twitches. All right, what's our next one? Make sure our person has an advanced directive. This should be sort of given for anybody that has a chronic debilitating condition. To support ventilation, we need a respiratory therapist. We need to make sure that BiPAP is nearby. I actually have in the resources for this module a patient, I think it's titled The Right to Die, or the ALS patient, The Right to Die state, but he actually wears a BiPAP, which is non-invasive ventilation, and he is actually shown slipping it on or off. That's a good thing to do when you're sleeping and if you're ever in respiratory distress. We can also do, the third option there is diaphragmatic pacing. They'll actually have a pacemaker connected to your diaphragm, and it will pace about 12 to 15 breaths per minute. Isn't that interesting? We could do a diaphragmatic pacemaker. No MRIs. The last option there is suctioning. Frequent suctioning, well, PRN, of the trach tube. You can imagine that we are going to, if somebody is showing signs and symptoms of acid-base imbalance, we might do an ABG. Maybe that is something that's going to let us know that they're not developing lactic acidosis from sitting around too much. They actually have respiratory acidosis. We are probably going to replace their PEG tube or G tube every 3 to 6 months. It's usually every 3 months. That's pretty common for anybody who has a PEG tube. Our dietitian needs to make sure and calculate that our patient can get enough fiber, because we're going to be prone to constipation by not moving around much, and that we get enough fluids, that we're meeting our daily water intake. This sort of goes for a person who is early ALS. Make sure to conserve their energy. Try not to overwhelm the person. It really kind of depends if you're going to cluster activities. You know, let's do everything at once, because they may not even have enough energy for a cluster of activities. We do want to make sure to keep them from getting contractions, so we're going to assist with range of motion exercises. And those are so simple, and they are so overlooked. And you'll notice whenever you do it with a patient, they are extremely grateful, because they know that's not exactly the first life-saving thing you want to do for a patient. You need to pass meds, you need to stay on time, you got a chart, but for you to go in there and notice that they can't even move their own arms, and to go ahead and perform range of motion for them, it just, something happens. I'm about to cry thinking about it. I've done that for a lot of my paraplegics. All right, you're going to possibly need 2 assistive devices, wheelchairs, and Hoyer lifts. Hoyer lifts will take them out of the bed to a chair. They have the stand to sit, or sit to stand kind. Sorry, I said that backwards. Sit to stand, where you just put like this little hammock behind their bottom, and it helps them pivot over. Yeah, that's about it for your patient with ALS.